Hello, good evening. I'm Jacquie White. I'm really pleased to be here this evening to talk to you about our systematic review. Unfortunately, the other Steves, who are both from the University of Huddersfield, or I've worked together on this project, can't be here. I'm going to talk through the background, the methods, our findings and the implications. I've been interested in this topic for a long time, and I publish a guideline on intramuscular long-acting antipsychotic injections. With this systematic review, we wanted to go broader than this because we thought that this was potentially a problem across the whole of nursing and for all sorts of different medicines products. So we know that intramuscular injection is an essential nursing competence. It has been for as long as I can remember, and it's highlighted, of course, in the future nurse standards in Annex B. And they're a common method of medicines administration. And I've put some examples on this slide of ones which mental health nurses perhaps be the most familiar with. But of course, all sorts of medicines may be prescribed by the intramuscular route. Antibiotics, for example, analgesia for pain, different things. But these ones on here, perhaps we're most familiar with. And needle length is indicated on every needle pack, usually in inches and millimetres, along with a gauge. And the gauge is based on something called the Stubbs scale for measuring wire, and it refers to the external diameter. Many people and some textbooks say it refers to the internal diameter, that is the lumen. That is not correct. It's the external diameter. And the needles are usually colour-coded by gauge, so we're familiar often with green needles. That refers to the gauge, that's a 21 gauge needle. And the most common length that we see used is 1.5 inches, which is 38 millimetres. But the needle must penetrate the muscle to deliver the medicine as the prescription intended, and we can't directly observe this. So we select needles based on clinical judgment and availability. And I've just highlighted here that if we have a pack where a medicine is supplied with needles in a pack by the manufacturer under the licence, we need to follow the instructions and use the needles in that pack. And quite often now there will be some relationship between either weight or body mass index to indicate which needle should be selected. But if we're using perhaps an older type of antipsychotic or we're delivering a vaccine, we'll be expected to select the needle for that particular medicine and for the individual patient. So if the injection doesn't get into the muscle, we would expect the way the medicine works to change. And I've mentioned on here pharmacokinetics, the way that the drug moves through and out of the body. And we'd also expect that to impact on the health outcomes, the positive health outcomes that the medicine's intended to treat or to benefit or to prevent. And we would expect to see more adverse effects. And an example of an adverse effect mental health nurses would be familiar with are granulomas, where the medicine gets encapsulated in the fat and you get these hard nodules that you can often feel. That's a granule of liquid encapsulated in fat in the tissue. It's called a granuloma. The injection site is chosen according to the licence, so not all medicines are licensed for all intramuscular injection sites. Some are, but not all are. The maximum volume that can be injected at a site, so the deltoid site, for example, can have a much lower volume than the gluteal sites. Patient preference, their consent, and our clinical judgment. And we know that there's gender differences in the distribution of subcutaneous fat. And we're also very aware that there's something called an obesity pandemic. There's a lot about this in the media. So obesity is increasing in the general population and also in people with long-term conditions. And it's associated with other long-term conditions, so multimorbidity, so diabetes, metabolic syndrome, that sort of thing, poor quality of life, and in some people, unfortunately, an earlier than expected death. So we set out to review the evidence on skin to muscle depth and to identify any implications of obesity status for the selection of the needle and of the intramuscular injection site. We included anything published in English in adults aged 18 years and over. We didn't include children and adolescents because of different distribution of fat and different dose considerations. Where the distance from the surface of the skin to muscle penetration had been measured at any intramuscular injection site using a medical test. That's what we were interested in. It had to be a medical test that generated images of the structure of the soft tissue, so that measurement could be made, and where this method of measurement and the obesity status were established using a standardised method, and where this was reported in the paper. We didn't restrict it to a specific care setting or design. So we designed a search strategy in Medline, which we'd be happy to share, we will publish, and then we translated that to CINAHL and M-based databases. We also scrutinised the reference list of papers we identified, but also other published literature, which I've listed here. And where there were only abstracts, we contacted study authors. And then we used something called the Joanna Briggs Institute checklist for quality appraisal. So this one that we use, the reference, the links on the slide, helps us make a judgment, really, a yes, no, or unclear judgment about 8 aspects of the methodology and how the authors reported the way that they attempted to reduce bias. This is our PRISMA diagram. Just to highlight here, I mean, we started off with 153 papers and we ended up with 13 in the analysis. We did a lot of this independently, and it was quite interesting that when we came together and discussed it, and even when we got to the quality appraisal stage, we were still identifying studies that should be excluded. Of the 13 identified studies, the main finding really was that everything was quite different. And this meant that we couldn't pool everything together in a meta-analysis. That's what we'd hoped to do. We weren't able to do that. Although they all adopted similar research designs, they were all observational, descriptive, cross-sectional designs, mostly ones where they'd recruited subjects and then conducted the scans and the measurements. 3 of them were retrospective. They were conducted across a number of different countries. The subject samples were either patients, mostly patients, and there were 2 studies where students or healthcare workers who'd come forward for hepatitis vaccinations had been recruited. They measured distance to the muscle using ultrasound, computed tomography, which is CT scans, or MRI scans, so they were different. Mostly ultrasound was used, and they investigated all 5 intramuscular sites which are available. I put a note on here because some recent work I've done shows highlighted this study from Japan where the rectus femoris site can no longer be recommended because of the risk of injury to the femoral artery and nerve. They adopted different measurement methods, digital calipers, lasers, to make the measurements. And they classified and reported obesity mostly using body mass index. One study used hip to waist ratio. And the main findings were that there was a clear correlation between obesity status and the distance from skin surface to muscle penetration. In women, skin surface to muscle exceeded 37 millimetre at both gluteal sites, and this was independent of obesity status or the measurement method. So this is really important because you remember that the standard common needle length for a green needle is 38 millimetres. The deltoid and the vastus lateralis injections were more likely to achieve muscle penetration, and this was the case for both genders. And the majority of the studies achieved the highest quality appraisal rating. There were 3 that didn't. 1 didn't report the setting, and 2 didn't report how they'd established inter-rater reliability. In terms of limitations, we might not have captured all the published evidence. There were different study populations used, and they were all convenience samples. Different methods used, like I said, for the measurements, and there were some methodological reporting problems. In terms of implications for nursing practice, because I know I'm going over time, the first one is to ensure that clinical stock supplies include a range of needle lengths, assess obesity status, just a reminder to only use needles supplied in packs. This one, perhaps the most contentious, always use the full needle length for the injection, inject to the hub. It seems that the practice of leaving 2 to 3 millimetres exterior to the surface of the skin, which is still highlighted in some textbooks, harks back to a time when needles were autoclaved and were weakened by that process. Needles are single use, they go through a quality process, they're highly unlikely to snap. They're much more likely not to get to the muscle if you don't inject them to the hub, although it's quite difficult to do this when you've spent a lot of time leaving some exterior to the skin. For the dorsogluteal site, in normal weight individuals of any gender, a 38mm needle is recommended. And a ventrogluteal site in men and normal weight women, 32mm is adequate, but in overweight women, a 38mm needle is required. We should avoid gluteal injection sites in obese individuals of any gender unless we have access to a 51mm needle, that's a 2-inch needle. For deltoid administration, 32mm is adequate in non-obese individuals, but 38mm should be used if they're assessed as obese. And in females and any overweight or obese individuals, consider using the deltoid or the vastus lateralis site if the product licence allows it and the patient consents. And we need more high quality experimental research really to find out if achieving muscle penetration actually improves health outcomes. And this is just coming to my final slide now. I'm just highlighting the latest 6th edition of the long-acting intramuscular injection guidance, if people would like to access that. So thank you, and I look forward to your questions.